It's like study, 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 study. And then your senior year, your priorities really do shift, but it's kind of that first exam can be sometimes like a reminder, like, oh yeah, I got to study for some things. And so in some years I've just been like, oh gosh, okay, we got a ways to go. But you guys overall did really, really well. Oops, lost that. Hold on, hopefully it'll come back. And I like to emphasize, that this stuff is review. It's not, um, I mean, there can be new stuff for sure because we're broadening and building, but there's a lot of review. So that's why in the junior year, if you're diligent and kind of disciplined with your studying, it makes it a little bit easier coming into this class, but not there's still a lot that you guys have to review, but it is it is not brand new material. So hopefully that helps. But there is, and I say it, I'm like a broken record. There is a fair amount of this kind of content on the national board. So you just want to make sure that you digest this class, even though it might feel a little kind of like off in the corner. Because you also do bring it into your clinic a lot. You'll bring it into your patient care. So today's cardiovascular, a lot of this is going to be review, a lot, a lot, a lot. I did have to add a few topics to special needs, just per the ADIA compendium. They emphasize a few things that I just didn't have in the class. And so I'm trying to like bring it in just a little bit, but not without like adding like too much detail and content because it just gets to be a lot. But so we're talking about some bleeding disorders at the end. There's like maybe 5 more slides I added that have to do with things like hemophilia and different bleeding disorders. So these are the objectives. We're going to talk about the etiology, risk factors, signs, symptoms of several different cardiovascular conditions from, did you have a question? No,
Just projector.
oh, I'm sorry. Was nobody going to say anything? Did I turn it on? Professor, you're like, I did raise my hand. Um, Professor Simmons said that it was acting up for your class on Wednesday. I have not had problems since the very beginning of the year, but now I see it's blinking. It's doing that blinking red thing instead of turning on. Why does it do this? And it's not muted. Oh, there we go. Okay. Yeah, it definitely is slow to respond. I almost think there's like a connection issue. Okay, it came up back here, so it'll come up in a second. All right, so yes, evaluate relationships between cardiovascular disease and periodontal disease. That's not as well defined as diabetes. They still feel like there's a lot of overlap there, but it's not as sort of laid out as clearly in the research. Discuss possible alterations for dental hygiene care for the appointments. That's sort of our big sort of take home. Identify types of cardiovascular disease surgery. One or two slides on that. It's sort of that's sort of just for your background knowledge to kind of understand what people do sometimes for surgical procedures around heart disease, and then oral manifestations of cardiovascular disease medications. I put there's like 3 tables in the back that have all the cardio meds, well, not all of them, but the ones that we talked about in farm, and then all of the oral manifestations. I'm not going to necessarily like heavy, just like the last exam, there were questions, but it's not the main point, but they're sprinkled in. And I just want to keep you on your toes because they're sprinkled in, in the national board for sure. I mean, there's a whole section of it. So it's just trying to keep that in your sort of in your mind. So we're going to talk about hypertension, coronary heart disease, dysrhythmias and arrhythmias, congestive heart failure, congenital heart disease, valvular and rheumatic heart disease, which sort of go hand in hand, and infective endocarditis, which pretty much relates mostly to a valvular condition, but there can be a few other specifics as to why somebody would, and we'll talk about that in relation to pre-medication. So why somebody might need a pre-med. So cardiovascular disease is basically just an alteration of the heart, the blood vessels. Blood's not flowing right. Something's impairing blood flow, oxygenation. There's blockage. There's something going on with the heart's leading cause of death. About one person every 33 seconds falls victim to their cardiovascular disease. Cardiovascular disease and periodontal disease do share a fair amount of risk factors, such as high blood pressure, smoking, people who smoke, diabetes, overweight, or just a sort of unhealthy sedentary lifestyle, and then excessive use of alcohol. So we see those as risk factors for periodontal disease, and we also see them as risk factors for cardiovascular disease. Total review, just looking at the blood pressure categories. Is this one that you guys use? Is it on your clinic? This is the same one. Okay, because I know that there was a little variation somewhere and I was like trying to make it all jive. And so if you ever feel like there's a discrepancy, just please like tell me, be like, there's a discrepancy. We learned this here and that there, and then I can try to correct everything. But remember, this is a big point is when you're looking at these categories, these ands and ors do make a difference. So you have to have both, or whichever one is higher will throw the patient into that higher category. And we know it can only be 1 point, and then all of a sudden they're an ASA2. But so you just have to be really aware of those ands and ors. It's not considered, I always find this a strange thing to say, but it was in the reading and the textbook, but it's not always considered a disease, but rather a physical finding or a symptom. And sometimes they don't really know what it is. I mean, it could certainly just be diet and lifestyle. It could be something with the kidneys. It could be stress. It could be genetic. There's always, but it's not necessarily classified like a disease the way, like coronary artery disease is or something like that. For hypertensive cardiovascular disease prevention and screening, we do our screening all the time. We do it, especially when we're going to give local anesthetic. We do it after we've given local anesthetic to see what they're going to walk out of the treatment room with, what type of blood pressure has it affected. I always thought it was really interesting because I always took blood pressure after my patients. Mostly that was a practice that I got in the habit of when I was at the perio practice, because that was what the doctor liked. When I was in general practice, they didn't emphasize that. But I always found it interesting with those patients, if they came in with high blood pressure, it was almost always lower, even after I'd given them 2-3 carpules of, local anesthetic with epi. And so I think obviously one, the stress is gone, the procedure's over, but local anesthetic in and of itself can lower blood pressure. Epi obviously can raise it, but sometimes it balances out. So it's a good thing to do though, just to see where your patient is standing. For drug therapies, just as a general reminder, we have the diuretics. They promote renal excretion of water and sodium ions, things like hydrochlorothiazide, or just easier to say HCTZ. Sympatholytic agents, they modify the sympathetic nerve activity of this autonomic nervous system, the sympathetic branch. And so an example of that is like lisinopril, vasodilators. They increase the size, they open up the vessel, they allow more blood to flow through. And so some examples of that are like our ARBs. Cozar is an example of an ARB, and what's it called again? Angiotensin receptor blocker, ARB. All of those. And those, just to say it, I know I said it a million times in pharm, but those, they definitely ask you all the different blood pressure meds. They love asking those on exams for the national board. So for some guidelines for the appointment, drug therapy can cause orthostatic hypotension. That's almost your number one thing that you want to think of when your patients are in your chair. Increased urination if they're on a diuretic. They could also have xerostomia if they're on a diuretic. Other meds could cause it too, obviously. Gingival enlargement if they're on a calcium channel blocker. There's some interactions with the NSAIDs that this doesn't say it here, but you might recall that from pharm. There's a lot of interaction with NSAIDs if they're on high blood pressure meds, so reviewing that as well. If they're uncontrolled, if they're just like sky high blood pressure, you're going to want to reschedule them. We have to go by our clinic cutoff, But when you're in private practice, your doctor may have a different sort of a different cutoff of their comfort level. So you just basically sync up with what your office is doing and stick to those protocols. But no matter what, you're the healthcare provider, you're a primary care provider in oral health and prevention, and you can give your own counseling to the patient if you just feel like their blood pressure is high. Even if you can still see them, you can still share information with them, caution them, refer them back to their physician, even if the dentist you work for is just not as on top of things. Shorter appointments, reduced anxiety. This is a blanket for a lot of these conditions throughout the whole semester. If anybody's stressed out or it's difficult for them to be at the office, you just in general want to make the appointment easier, reduce stress, possibly shorten the appointment. I mean, that's just sort of common sense. But it goes to it applies to a lot of different of those these different types of conditions. For local anesthetic, if someone has controlled blood pressure, like they have high blood pressure, but it's relatively controlled. You can obviously still use epi. You always want to use kind of caution, common sense, think about it, think about what their risks are, what's the pros and cons of doing it. Should you just use mepivacaine? Have they had any sort of episodes of anything, or are they just really a little elevated? They take their blood pressure, everything's fine. They take their meds, everything's fine. And of course, in general, we can max it out at 2 carbs is plenty safe to sort of for any cardiovascular patient with any kind of history of heart attack or maybe a little bit more serious condition. And if you don't know, and your dentist doesn't seem to know, always feel 100% comfortable, and you should reach out to cardiologists if they're under the care of a cardiologist. Always feel like that's a route you can do, is reach out to other professions. Okay, so our protocol, I know I updated this last year. I hope Professor Santoro didn't change anything, because this is last year's. So you guys tell me if you notice anything. But I think it's the same. We never talked about changing it, so I think it's the same. So for our cutoff, individuals without comorbidity. So these designations are really, really important. Without a comorbidity. What's a comorbidity?
Condition like diabetes.
Yes, yeah, like something else they have. They got something else, diabetes. They have some other condition. Usually there's a good list of them. Diabetes is by far probably going to be one of your most common ones, especially if they have cardiovascular. But it could be something else. It could be a thyroid condition. It could be, I'm trying to think of what else it could be. But there Yes, it could be like some kind of respiratory thing. It could be some other autoimmune condition, lupus, I don't know. I mean, it could be rheumatoid arthritis. So a comorbidity is they have something else, some other systemic condition that they are dealing with. So if they have none without a comorbidity, then you can go all the way up to 180 over 110, which is quite high. I mean, 110 for diastolic, I'd be like, oh gosh. But we say that we'll still see them. And to be honest, in private practice, that's quite common. I did work for a doctor that cut off at 100 with the diastolic, and they just were not comfortable above 100 for the diastolic, but that just depends on the dentist. So now with comorbidities, it's lower, 160 over 100. Hypertensive crisis, 180 over and/or over 120 for a blood pressure. Now, people who are in extreme pain, they're, like in shock or something like that, or just like mostly pain and a lot of stress and anxiety. If something big is happening, they can easily have short periods of time when their blood pressure skyrockets. But if they just stroll in off the street acting like everything's fine and their blood pressure is like that, then that is not a good thing. Okay. Coronary heart disease, CHD, associated with disorders such as atherosclerotic heart disease, angina pectoris, coronary insufficiency, and myocardial infarction, which is also known as what?
Heart attack.
Heart attack, that's right. So, CHD, so what is it? Insufficient blood flow from coronary arteries into the heart or the myocardium, the muscles and the all the different parts of the heart muscles. And this can include, like I just said, those it's just repeating it. So a major cause of this, the big culprit is atherosclerotic disease or atherosclerosis, which is the narrowing of the lumen of all the vessels. And it's usually almost always due to a buildup of this, lipoproteins or the fibrofatty substances. Now, interestingly enough, a lot of times the cholesterol and the plaque buildup is a result of inflammation. And so it's trying to get to those areas where there's inflammation and patch it. And then on top of that, you kind of get this like cascading event, and it can be very slow process. And the person can sort of adapt to the narrowing of the lumen. And so it's not always that is the huge issue as much as if it goes to, gets too narrow, then of course that's a problem. Or if a piece breaks off and blocks something. So that's the real danger with the whole thing that's happening. Angina pectoris is another sort of resulting of this oftentimes reduced oxygen due to like the narrowing of the lumen of the vessels. So inadequate oxygen flow. The goal for somebody who has angina pectoris is really just to sort of reduce the demand of the heart, because if the heart starts pumping hard and the body's demanding oxygen, that's when they get the pain. So pain with stress, pain with a physical exertion, going upstairs, rushing, those kinds of things. So of course, for us, we would like to again keep stress low, identify the condition, how often they have pain, how often they experience some kind of an anginal episode, make sure that they brought their nitroglycerin with them, make sure that their nitroglycerin is not expired, ask them when the last time they had to take it and did it resolve the issue. So all of these things, you can think about it almost like an asthmatic attack. Like, okay, how often do you have your meds? How severe was it? Have you ever gone to the hospital because of it? Like just all of these sort of common sense, like I just want to know your story so I'm prepared for if something freaky happens. That's like the bottom line, basically. So monitor and record the patient's vitals. Remember that after they open the container of nitroglycerin, they only have 6 months. So if they're one of these people that are like, oh yeah, I keep my nitroglycerin, I've had the same bottle for 3 years, you could be like, oh my gosh, okay, well, let me school you on something. And so, because they might not, like maybe they got diagnosed, but it's just very minor and they just aren't aware. And nobody on their medical side is keeping up with them. So 6 months, they have to get new nitroglycerin. And then a medical emergency review, if they have an anginal attack or an anginal episode, dose every 5 minutes, up to 3 times. And if there's no improvement, then you're obviously going to call EMS. Okay, so for a heart attack or myocardial infarction, no or reduced blood flow through one of the coronary arteries. So there's no blood flow going somewhere, and a part of the heart is dying or is going to die if nothing changes because there's no oxygenation to the actual pump that needs to send oxygenated blood everywhere in your body. So that's a problem. So but if that happens and the person has survived it, I just updated this literally in my office this morning. That's how last minute it was. But it dawned on me that there have been different protocols. And so this said, if anybody looked at this or if anybody downloaded an earlier version and it says 30 days, I rechecked it and I checked it with the ADA and it's a 6 week because basically they're at the highest risk within 30 days of a heart attack. Oh, hi, Brenda. I thought you were a student.
No, how do you on the phone since you can't get into your Zoom link?
Oh, I have it on. Oh,
resending it to her, maybe she.
Oh, yes. You know what? There's something weird about it's something with the one that is uploaded in Moodle. So I'll send her, let me send her this one in an email real quick. Okay. Tell her I'm sorry about that. Let me pause the recording.
Yeah, almost.
Okay. I'm gonna go back in. All right. So what was I saying? So 30 days is how long it takes, or the patient is at most vulnerable state in 30 days. And they basically say no sort of elective or anything that's dental work that you could postpone or put off for 6 weeks. Now, the American Heart Association used to say 6 months. And so that's why there's been like some people just did different things, but that basically is kind of old information. Now they're if somebody has survived a heart attack and their cardiologist says they're stable, then after 6 weeks after their heart attack, they could come in and have cleaning and things. They might not want to have root canals and extractions. They might, but if they have some major infection going on, that's not healthy for their cardiovascular system. And so they would weigh those pros and cons. But basically 6 weeks is our sort of window that we want to wait. Okay, drug therapy, remember, and we'll touch on this throughout, but anticoagulants, digitalis or digoxin, that's that weird one that can kind of make patients a little bit more gaggy because it sort of affects the GI system. And then antihypertensive drugs that like we've been going over. I have a lot of notes in this PowerPoint, so I would recommend reading through all the notes. All my questions will come off of the slide, but the notes are really, really good for background information. And there's just so much information on cardiovascular disease, it's hard to just summarize it. Okay, so for appointment consideration, 6 weeks. If they're stable, no problem. If they're still unstable, they're not going to call you. They're not going to be like, I want a cleaning. If they're heavily, if they're in danger of dying, they're not going to worry too much about getting their teeth cleaned. So they're probably going to wait. But you can always reach out to the cardiologist. Short morning appointments, adequate pain control so they can have nitrous, just keeping them really comfortable. And then you can talk to them about their periodontal disease status, their lifestyle changes that might make a difference for all those different components of their life. We're moving. So dysrhythmias and arrhythmias, what are they? They're kind of interchangeable terms. It just basically has to do with the coronary heart disease is like physically blocking things up in the heart. Dysrhythmias and arrhythmias are the electrical. So your heart, physically needs to move blood and then electrically needs to be stimulated to pump. So those are the two mechanisms. And if either one of those fails, your heart is not going to be happy. So terms are interchangeable. It is a dysfunction of the heart rate and rhythm that manifests as heart palpitations or just losing the rhythm, which could potentially be fatal. So dysrhythmia is usually associated with a diseased heart. So there's usually something happening that's specifically related to disease. And then when the word arrhythmia is used, it can be less specific about a disease and more like emotional stress or, like high physical exercise or something going on. And so it could even be hormonal or something that's like transient. I don't know if said this. I probably say it every time in this class, so I feel like I don't know who I said it to, but like every time I was pregnant, I would feel a little fluttering. And so I told my doctor and they're like, oh, it's your hormones. And I'm like, oh, okay, great. And then whenever I'm like stressed, but not overly stressed. Like I'm gonna do something that's new, but it's not like I'm freaking out. I'm not like in there like feeling like I'm gonna die or anything, but I my stress level is just a little higher. When I get quiet, I can feel like little fluttering. And so I think that's those, they're kind of normal, like your heart just like it's like it's bubbling. I don't know what it does. But those things can happen for different reasons. So for dysrhythmias and arrhythmias, dysfunction of the heart rate and the rhythm, palpitations, we already said that. So disturbance of the nerve impulses. And this basically kind of says it can also electrolyte imbalance. That's another one I didn't mention. So that could be really significant for somebody who maybe is suffering from some kind of an eating disorder, or if you just are busy and you haven't gotten your nutrients and you've kind of neglected that part, or you've exercised a ton, haven't replaced your electrolytes. So, different reasons that could happen. It can be diagnosed through like an EKG or an ECG at the hospital, doctor's office, or some people can bring home a monitor and wear it 24 hours so that they don't miss it. You go into the office, you sit down, they might miss something because it's only like a small window, but if you can wear something the whole time, that makes a big difference. So a couple common terms, I know some of these you guys know really well already. Bradycardia, decreased slow heart rate, usually below 60 beats per minute. Tachycardia, fast heart rate, usually above 100 beats per minute. Atrial fibrillation. This is usually some kind of arrhythmia in the atrium, the upper portion of the heart. And then premature ventricular contractions, pauses in an otherwise normal heart rhythm. I don't know if that's what I experienced, but kind of sounds like it because I don't think my rhythm was off. It was just these little things that would happen. Ventricular fibrillation, that's the one you really want to commit to memory because that's the scary one. Ventricular fibrillation, if someone goes into that mode, they are not going to survive unless they get shocked out of it. So that's the big one. That basically your heart does not have a pumping rhythm. It's just like a jellyfish. It's just like sitting there wiggling and nothing is being pumped. So that ventricular fibrillation is the big one. And then heart block interfere, it's just kind of a term that means interference with the electrical pulses that controls the muscles and the pumping. So pacemakers, nowadays, patients oftentimes have a shielded pacemaker. I think it would be very, very rare, unless somebody that, was quite older, came in and had had a pacemaker placed a long time ago. Always ask them, they should know. But if somebody's pacemaker is unshielded, they could have interference with our electromagnetic like wavelengths from anything that's electric. I mean, anything like microwaves, cell phones, ultrasonic cleaners. That's the biggest thing that's going to have a large electromagnetic emit some kind of electromagnetic wave. I feel like I'm not saying the term right, but I hope you guys know what I mean. Because that's going to be close to the patient. It's quite strong. And if you think about it, our clinic, at least half of you are probably going to be using, maybe not half, but probably close to half are going to be using a piezo or a Cavitron. And that's emitting lots of EMF, electromagnetic frequency, lot of EMF. So if somebody does have an unshielded pacemaker, it could really make a difference. It could be dangerous, but it's very unlikely, but it's still something you want to ask them about. You could always put a lead apron on them. You can not use the ultrasonic, and then you could, talk to them about things their doctors, if their doctor feels like it's a risk and just kind of get more information, call the cardiologist. If something's going on with their pacemaker, they're going to have difficulty breathing. They're going to feel dizzy. They could have chest pain. Their pulse is going to be very irregular. And so there's going to be definitely signs and symptoms. And then turn off all electrical interferences and call 911 if they end up having like an incident. No pre-med is typically needed for somebody that has dysrhythmias or arrhythmias. Basically, we'll talk about what the major requirements for pre-med is, but you do want to just if you see that, a lot of times they might take a med like digoxin, and that's just that weird, wacky one that keeps coming up. So you just want to know what's the kind of patient that would be taking digitalis or digoxin. Unshielded, less common. We already talked about all these. Monitor their vitals and monitor the patient throughout the appointment. For congestive heart failure, usually they can have it in different parts of their heart. It can affect their different parts of their bodies. You could see different. It can manifest. Symptoms can manifest in different ways when somebody has congestive heart failure, and they usually know quite a bit about their condition. They're usually under close care of a physician and a cardiologist. Syndrome characterized by myocardial dysfunction that leads to diminished cardiac output, abnormal circulatory congestion. So that's when we start to see things like edema in the ankles and the lower legs. Their heart is just not, their output is not strong enough, and their circulation is not strong enough to move the blood. And so they start to get fluid accumulation. They can get fluid accumulation in their lungs, and they're not comfortable laying all the way back. They can have fluid accumulation in their lower legs. They're not going to heal as well. They might have more like larger veins, and it might be kind of like their vascularity is more obvious, and they might have bruising and stuff easier on their legs. Some other things though that for the heart would be tachycardia, ventricular dilation, and an enlarged heart muscle. Yeah.
Do we have a clinical cutoff for pulse?
Ooh. Well, I've seen over 100.
I've been over 100.
You're like, I've been over. 60 to 100 would, yeah. That's a great specific question though. I don't think we have designated like a cutoff. So that's like a really good, I mean, definitely, like you said, like there's that normal range. If someone was way out of it, you'd be like, it would flag you for sure. But I'll bring that up. That's a really good point. We should probably talk about it and have something in the clinic manual. See, you guys are always thinking, always using your brains. That's good. Etiology for congestive heart failure is again atherosclerosis, hypertension, valvular heart disease, pericarditis, there's so many different things that can in general just weaken the heart and affect the heart. So oftentimes if somebody has congestive heart disease, they have other heart issues. So it's kind of like almost like this umbrella for they have like all these kind of things that have been happening to them for a number of years, and now it's manifested to CHD. So removal of cause, lifestyle changes, dietary controls, medication, those are all sort of usually what takes place. Closely monitored by the physician. If they're stable, you might not have to monitor anything greatly. Maybe like chair position, besides all your other things like checking their medications and asking them about, how stable they are and what anything exciting has been happening with their heart. Hopefully not. Other than that, you might not have to do a lot besides consider just their regular oral hygiene and their oral disease risks. And then you might have to consider, putting them back in the chair if they can handle going back farther, and then epinephrine with local anesthetic. So that not too many things, but this considered, hypertension, valvular heart disease, if they've had a heart attack. Again, there's the digitalis, and then difficulty breathing if they sit back too far, minimize stress, may need to reduce ultrasonic. The only reason that gets brought up from time to time throughout the whole course is because it can be stressful for somebody to handle water, and it can be hard for us to manage the water in the back of their throat. And if you're really good at that and you dialed your piezo or your ultrasonic in to just the right flow of water that's just enough to cool it and flush, but not like just like a garden hose in their mouth, then you're going to be able to use it better. But if you have an ultrasonic just flows heavy and you're not great at keeping the patient kind of suctioned out, it can be stressful. And especially for older population, they can choke on the water much easier. And so you always have to just kind of consider that. And then the air powder polisher it's sort of the first version of the guided biofilm. What is that thing called? GBR. GBT? Guided biofilm what? Therapy? Therapy? Thank you. I never used it in practice. We actually had one come into our practice and it was like, look at this. And we were all like, oh, and then they took it away and we never got to use it. So I know it was a bummer, but hopefully one day I'll get to play with one. But the sodium is a little bit more of something that we thought of more with the air powder polish. It was like the first generation idea of the GBT, and it was like larger particles. You could not go subgingival. You can go subgingival with the guided biofilm therapy. And so there's some pretty significant differences. But so if you ever see that word air powder polisher and you're like, what is she even talking about? That's what that is. And it would blast. It was like a little sandblaster. You blast away stain and plaque and stuff, but you had to use it supragingivally only, and it make a huge powdery mess. And if one of them was sodium bicarbonate, so if they had sodium restrictions, we couldn't use it on them. Okay. So congenital heart disease. So what is congenital heart disease? Abnormality of the heart, structure and function, and it is developed before birth. Oftentimes this is where pre-med comes in. Very, very oftentimes. So residual defects following a repair, a palliative shunt, first 6 months after surgery, very, very oftentimes they're going to be on some kind of an antibiotic pre-medication. Management of any cardiovascular complications resulting from the defect, and consult with the physician about surgeries, medications, their overall status, and their need for ongoing pre-med. Now, if somebody's had a prosthetic valve placed, they will always need pre-med. That is a weak area in their heart where bacteria can accumulate, and that word bacteremia, you guys are familiar with that word, bacteria in the blood. That happens, you can give yourself a bacteremia when you floss, but the better oral hygiene you have, the less biofilm build up. But when you go in there and deep clean and really cause a lot of bleeding, there's going to be more bacteria introduced into the blood, and that valve is a weak spot. It could bacteria biofilm could aggregate around it and cause major problems for them. Okay, so for a valvular heart defect, cardiovascular damage from malfunctioning heart valve, the mitral valve is the main one that we see, like a sort of a prolapse or a dysfunction. But there's the aortic valve, there's the tricuspid valve. But like I said, mostly we see it in the mitral valve. It's mitral valve prolapse is almost always when someone says, oh, I have a heart murmur or I have mitral valve prolapse, that's a very common thing that you'll hear. And prolapse just means it flops backwards. It just doesn't close normal. It doesn't like go ka-chunk and close. It kind of goes floppy flop, and it makes a noise. And that noise is the murmur. Stenosis may develop a backflow of blood from incomplete valve closure. And so that also, I think, adds to the noise as well. Echocardiogram or ultrasound is how they would diagnose it. They'd watch the valves work and see what they're doing. Now, valvular heart defects can be associated with a couple things. Rheumatic fever can lead to rheumatic heart disease. It used to be something that we would get all worked up about and be like, now, have you ever had rheumatic fever? And we were very serious about it, and we were really worried about it, and we'd mark it all up on their medical history. But as time's gone by, we've realized that rheumatic fever, even if they had it, a very low chance that they actually had some major heart damage. It's possible. So we still consider it. Like if you see rheumatic fever, you want to have a follow-up question of, oh, I see you've had rheumatic fever. Did you have any residual heart damage after you had that and it cleared up and went away? Did you have any damage to the heart? And the person would know. And so rheumatic fever is one risk factor, congenital defects, and then if they had infective endocarditis due to just something else, and it damaged their heart, that's another risk factor. So good daily oral hygiene. The less bacteria that accumulates in the mouth, the lower the biofilm bacterial load in the mouth, just the better, right? Overall better. So a patient who had a prosthetic valve requires a pre-med and then regular maintenance schedule. So keeping them healthy, keeping their mouth healthy, super important. For valvular heart defect, oftentimes they're going to be worried about also their clotting time, making sure the blood flows really well through their body. If their blood is clots more, or if they have more fibrin or all the different little things in the blood that could make it sluggish, this is dangerous for somebody with a prosthetic valve. So in patients taking anticoagulants like heparin, warfarin, or Coumadin, or Plavix, we want to know their their clotting time. I talk a little bit more about this at the end because we kind of revisit it, but normal prothrombin time is between 11 and 14 seconds, but basically less than 20 is good. Laboratory consistency, the INR, the International Normalization Ratio. I think I read somewhere over the weekend when I was adding the bleeding disorders that 1 is normal, but this says 1.5. But treatment can be performed when between 2 and 3. So what we do is different than like an oral surgeon, right? I mean, we're going to consider things a little bit different than if someone is doing like major surgery. We always consult the physician. We want to scale just one area at a time. We want to stay really localized and see the results of the clotting and how things are clotting. Is it normal? Are they just bleeding and bleeding and bleeding and they're not stopping? We don't want to just be buzzing all over the mouth and not get a good idea of where that bleeding is coming from. So stay local. Begin in the area of the least inflammation, because if they bleed I always want to say stuffed pig, but it's like a stuck pig, right? Is that the phrase? Stuck pig? I don't know.
Stuff.
If they bleed a lot, you want to know in the area of the least inflammation and then go from there. Periodically check to make sure they're clotting, and then always emphasize good OHI. So I already basically said the little spiel about the rheumatic fever. Valvular damage may lead to heart murmur, turbulent flow of blood through the valve, but not always. So just because they have had rheumatic fever does not mean that they are going to need a pre-med. They only need a pre-med if, if their cardiologist has said they need the pre-med, or if it's led to some kind of, prosthetic valve or something like that. So always pre-procedural antimicrobial rinse. That's going to help reduce the risk of a bacteremia. Good OHI, good habits. And they just don't want that inflammation and plaque biofilm to build up, so they don't do a self-induced bacteremia. I wonder if I can get through. Maybe this is a good place to just take a quick break because we're almost, yeah, I have a case and I really want you guys to be able to work on these together. So maybe we'll do, what time is it right now? Let me go just 3 more minutes and then we'll take a 10-minute break. Okay. Okay, so for infective endocarditis, so what is it? The endocardium is, and there's an infection basically in parts of the heart. And so infection of the endocardium, heart valves, or the cardiac prosthesis resulting from microbial invasion. So some area in the heart has gotten an infection, which is really bad. The heart does not want to have an infection. So it's usually caused by a staph or a strep. for the most part, but it could be yeast, there's so much stuff in our mouth. We have all kinds of crazy things. It used to be just like we thought bacteria was the only culprit to everything, but we have a vast array of viruses and funguses and yeasts and protozoas and all kind of weird stuff in our mouth. So they can find other things in these infections when they look closely. Infective, so that's why we call it infective endocarditis and not just bacterial endocarditis, because it can be caused by other things. So a person is at risk if they've had a previous endocarditis. If they've had it, their heart is going to be much more susceptible to it happening again. And people have had it for kind of random feeling reasons, even if they didn't have a prosthetic valve. I remember in Arizona in my general practice, a guy had infective endocarditis after having dental work. And he was in the hospital for like, oh my gosh, like 10 days. And it took him a long time to recover after, and he almost died. And he did not have a prosthetic valve. It just kind of happened. And so weird things can happen from time to time. And who knows exactly, why he might have had something weak about his heart, that nobody had diagnosed. I mean, that could have been what was going on. So, but invasive dental or dental hygiene or dental hygiene therapy, defined as procedures that manipulate the soft tissue. So it's really important for you to know what invasive means. You might think invasive means cutting, but it really just means manipulating the tissue so that you could cause bleeding. So invasive procedures are like probing. So it's basically anything where you have manipulated the soft tissue. Manipulation of the periapical area of the tooth, oral mucosa, perforation on patients with a previous condition. Artificial heart valve, that's the next big one. Serious congenital heart condition, a heart transplant is also obviously a really big deal, especially if they have any kind of valvular problems. Identify high-risk individuals via their health history. Make sure they're taking the antibiotic in the right way, that they remembered to take it. Now, if like you just totally space it, you're having a crazy day, busy day, you're running late, you grab your patient, you start cleaning their teeth, and all of a sudden you go, oh my gosh, they're supposed to take their pre-med, and I didn't even ask them. And you can still give them pre-med after the appointment. They haven't hit some threshold of danger where you've already started manipulating the tissue. You can give it to them afterwards. Pre-procedural rinse to lower bacteria. Try to, avoid unnecessary trauma when you're cleaning. When somebody has really deep pockets, there's tons of inflammation, you can bust through that junctional epithelium pretty darn easy if they're really, really like have bad infection. And so you want to just always be, sometimes you have to use a lot of pressure, a lot of lateral pressure. You're down there for a really long time. And you just want to try and be as precise and careful when you're doing those procedures as you possibly can, because you just want to try and avoid undue damage. Help client maintain good oral health, encourage regular continued care, 9 to 14 days between prophylactic antibiotic pre-medication, and then pay attention to their like penicillin allergies, because a lot of times it's amoxicillin that we give them. So if they have a penicillin allergy, you have to be aware of that. There's your overall review of the protocol. Usually we'll do it an hour before the procedure. And oh, I went over a minute. Okay, let's take a break. We'll talk about surgery when we come back. So we'll come back at 1 or 2 minutes past 10. I'll pause this here. I'm recording. Okay. So types of surgery. So again, I don't really test very much on this. I mean, there might be a question about a stent on something, and people kind of blow by this. So I don't want to minimize it too much, but I think I have asked questions where it had like different options for heart surgery, and several people were like, "What's a stent?" I'm like, "It was on the PowerPoint." So now I try and say it a little bit more. But I don't expect you to be like stress out over this slide, but just kind of have a general understanding of the kind of couple things that might be seen in a surgery, because your patient might put it down on their medical history, or or so you kind of, or very likely they would put it on. So you just want to have an understanding. So angioplasty, most common closed heart surgery. They use a catheter or a long tube into the coronary artery with a balloon that inflates, and to inflates the vessel to increase the flow. There's all kinds of different ways that these things are done. It's far above our pay grade, so I don't really worry too much about it. But if you have a patient that has something like that, take a minute to talk to them about their experience. It adds to your comfort level and your body of knowledge, and just it's just that's one of the funnest things about being a dental hygienist, is talking to all your different patients about all their different experiences, whether it's their career, where they travel, or their weird little medical idiosyncrasies. Like, you're just going to learn a lot, just by the sheer number of people you get to communicate with. And that was always one of my favorite things about the job. But anyways, that was off topic. So stents, placed in conjunction with angioplasty. So they expand it, blow it up, and then they place something to kind of hold it open. Mesh-like metal stent placed in the to open up the area so the blood flows better. Bypass surgery, sometimes they'll they'll harvest arteries from one area, and then they'll graft them in, so that or they bypass it altogether, just if it's something totally blocked. So it could be a single, double, triple bypass. You've heard those terms before. Valvular defect or repair, that's really the big one you want to be aware of, because obviously they might have a prosthetic valve, or a fake prosthetic is like fake, right? The fake valve. And they're going to need the pre-med. Heart transplant would be a massive surgery. And very oftentimes those individuals will be on immunosuppressants. So anytime somebody's immune system is suppressed, there's all kinds of funky things that go on. They're more susceptible to different diseases or infections, or, just there might be opportunistic infections like yeast and different things like that. They could have a masking of their periodontal disease. It could sort of not look as bad as it is. And so there's all kinds of different things that you kind of have to just be aware of when someone's on an immunosuppressant. Let's see here. Okay, so some oral manifestations of the cardiovascular meds. This is just sort of not getting down into which drug causes what, but just knowing that these are all things that are kind of that they're at risk for. So higher risk in general of oral disease. So you always, with everybody, but cardiovascular patients in particular, you want to encourage them to have regular care and a really good habit of good oral hygiene. They could have xerostomia from a vast array of different medications. Depending on certain blood pressure meds or different meds, they could have altered taste, metallic or strange tastes from different meds. They could have gingival enlargement, hyperplasia. They could have salivary gland pain. They could have exaggerated conditions in their mouth. They could make it look worse than it is, or it could just be worse. It could, something that wouldn't normally be that big of a deal could be exaggerated on a patient, depending on what kind of meds they're on. Opportunistic infections, that's that, and immunosuppression. Spontaneous bleeding, that's with the bleeding disorders or the anticoagulants. And I have this all summarized to be more specific, because this list doesn't really help, because it's like, well, what med does that? So I don't love this slide, but that's why I put the slides that have the tables for you guys to kind of read through it and kind of match up the medications with the oral manifestations. Not that you have to memorize it hardcore, but being familiar with it, even, keeping it making like laminated cards, that is not a bad idea because these medications are medications that you'll see more often than, some other, less common autoimmune condition or, or neurological disease, or, you're not going to see as many patients with cystic fibrosis, but you are going to see a lot more patients with cardiovascular disease. So it's not a bad idea to make yourself little, laminated cards like this on a ring. You always have Lexapro. I mean, that's at your fingertips, but sometimes it's nice if you have an area of resources in your operatory really close at hand. So we're not going to go over these, but I do want you to make sure you kind of read through them. Just kind of remind yourself of these names, what their indication for use, and oral implications as well. And it's not exhaustive, but it's a lot of really common ones. So there's a fair amount there. Okay. We are going to totally have time today. I'm very excited. Okay, so bleeding disorders. There was more I could have written, but I didn't want to add like another 30 minutes just for bleeding disorders. And so I tried to really pull like what's sort of the biggest deal. There was some words, some verbiage that I felt like, if I'm wondering what this word means, I bet other people are. So there's a few words I wanted to kind of clear up and then just talk about some basics of some of the most common. So identify various bleeding disorders and the basic etiology. Really, it's not all of them, but it's the most common. Discuss oral manifestations, dental management, understand specific patient education and OHI. And then discuss any contraindications for dental care. So I liked this slide because when I was researching it in the different sources I was looking up, they kept using these words. Petechiae, I knew because we talk about that. And maybe you guys, maybe since you're closer to oral pathology, maybe these terms are familiar to you. I don't teach oral pathology and I don't see patients on a regular basis. So I was like, what's ecchymosis again? And so I liked this slide because it helped remind me. Basically, they're all forms of like bruising or blood accumulation under the skin. Hematoma is another one. We use the word hematoma a lot, but we know that kind of comes with blood accumulation and like swelling. We think of a hematoma after giving a PSA, right? And we think of petechiae as like little tiny dots. But purpura are a little bit larger, between 4 and 10 millimeters. And then the ecchymosis, this is more of your common, just kind of a bruise, and it's larger. So that's going to be the largest. Okay, so identify past bleeding. So how you're going to deal with this with your patient, you're going to identify past bleeding issues. Ask about previous bleeding episodes. Do they get those things easily, or do you observe them? The petechiae, the ecchymosis, the bruising, the hematomas, excessive gingival bleeding. Do they bleed when they brush their teeth? Do they bleed when they floss? That obviously could have nothing to do with a bleeding disorder and just be bad perio, but you just kind of want to get familiar with your patient. History of excessive nosebleeds or oral bleeding, family history of hemophilia, von Wilderson. See, I don't even remember it. Wilderbrand, Wildbrands. Oh my gosh, von Wildbrands. I haven't committed this all to memory yet. So family history of one of these genetic disorders, any anticoagulants or blood thinners that they're on, excessive alcohol use can interfere with coagulation. And then of course you guys are doing your EOIO, so you're looking for abnormalities. You're looking for these the purpura and the bruising and the petechiae and all of that. So these are sort of very broad categories of bleeding disorders, and I really only go into the highlighted ones. But I just wanted you to be aware that there are other things that are more rare. And so as much as I'm not going to test you beyond this, but as far as your interest and you want to just delve into bleeding disorders, you certainly Can, and you might just look and see if Darby has anything. You guys, that textbook is meant for you to fill in the back knowledge that we just can't get to in class, especially as it relates to the national board. So if there is anything in Darby, beyond this, I would, but other than that, if it's not there, it's probably not going to be on the national board. But coagulation factor deficiency. So they're missing factors in the blood that coagulate the blood. So hemophilia A and B, von Willebrand's disease, liver disease can lead to coagulation issues, vitamin K deficiency. The antidote to excessive warfarin, like if somebody is ODing on warfarin, the antidote is vitamin K. And so that's like a direct kind of correlation there. So if they have a vitamin K deficiency, they might bleed more. Then there's platelet disorders. I basically just sort of said thrombocytopenia because under thrombocytopenia, there's like immune modulated, non-immune modulated or mediated, congenital, acquired. And, it can be from a drug, it can be genetic, it can be, like all these things. And it's just too much. And so I just wanted you to know that there are platelet disorders. And in general, that sort of broadly categorizes thrombocytopenia. Then there's vascular disorders, and those can show up in different syndromes and different conditions. Somebody has scurvy, there could they if I the perpu I don't really know. That was in the thing, but I'm not sure the purpura. I'm not exactly sure what that is connected to. It was under the list. I'm gonna have to go back and check that, and maybe I'll make a note in the side note there. But Cushing syndrome, and then the Ehlers-Danlos syndrome as well. So there's different things that can lead to vascular disorders that have to do with bleeding. So people bruise easier or what have you. And then there's fibrinolytic defects. And so this is caused from different things that I really don't have much to share with you because I really don't understand a lot of it. It's just well out of my wheelhouse. Never heard of most of these things. I'm just kind of saying there it is, but I'm definitely not going to test you on it. So we're going to go back and focus just a little bit more on hemophilia. So hemophilia A, it is a deficiency of clotting factor. What's V? Is V 5 or 10? V is 5, right? So clotting factor 8. You guys can help me through this. We'll learn it together. So deficiency in clotting factor 8, it is inherited on the X-linked recessive trait. So it's carried through the male because only the males have the X's, right? And so it's an inherited X-linked recessive trait. Symptoms: delayed bleeding, ecchymosis, so that bruising, deep hematomas, the epistaxis is nosebleed, spontaneous bleeding. Treatment is very complicated. All of what I was reading over the weekend, they're just looking to increase the factor 8, and they do it through, essentially like blood transfusions, and there's some medications as well. And it's like but they want to make sure the blood is like pure. And so they use monoclonal antibodies. They don't want any viruses or any kind of funky stuff in the blood. And they treat it in a way to get out the factor. So it is very complicated. If you are a surgeon, if you are doing something major, you're going to be very concerned about this. Make sure that the patient is taking all the right steps for whatever needs to happen. If you're the dental hygienist doing cleaning, you're still going to have to, everything has to be cleared with the physician, has to be cleared with the dentist. It's going to be a case that a lot more attention is paid to. They are not just going to waltz in off the street, sit down in your chair, and you're going to start. It's like, this patient has hemophilia. These are all the things that have taken place so that we can safely treat this patient. You're not going to be alone in this endeavor, which I think is a big take-home point. There is a rinse that I had also never heard of. This tranexamic acid is an oral rinse, helps prevent post-operative bleeding from surgical wounds. I don't know why I have a few extra. I have a P and a dash there. I have to fix that. That's probably things that oral surgeons have in their office. They're probably aware of that. I've never had to give that to a patient. I know there's also other hemostatic. I was telling some of you that were sitting by me in restorative on Friday how my dad had some of the hemostatic gel placed around his crown because he's on Plavix, so he was bleeding a lot, and it has like ferric sulfate and ammonia or aluminum sulfuric acid. I don't know. It's has all kinds of weird stuff. And it's a hemostatic agent or gel. And so they put it all around his crown. And of course, it got on his tongue, and he was like, it tasted so bad. And then his tongue, half of his tongue was black. And he took a picture of it because he's like, my mom's like, how's your crown? Because my mom was in town last week visiting. So she was with me and he was in Arizona. And my mom's like, how was your crown? And he's like, oh, fine. Half my tongue is black. I'm like, Dad, take a picture. And so it was like black, and then it diffused across the midline. So I was like, that looks like something his tongue came in contact with. And so I was quizzing him, and then he told me about the agent that they used, and I looked it up, and sure enough, it can temporarily turn your tissue black. And so I think I was talking to Rachel. I was like, why wouldn't they tell you? By the way, it might turn your tissue black. It was just like crazy to me. But so anyways, this mouth rinse that I have here on the PowerPoint slide, I don't know if it does that or not. But the only hemostatic agents I've ever known are the ones that we use in, for things like that, for crowns or so there are other things out there that probably oral surgeons and periodontists and people who do more invasive things would be aware of. My formatting messed up here. I apologize. I'll fix that. This was supposed to be two different columns. So for hemophilia B, we have a deficiency of factor 9. And then the therapy, again, they're trying to increase that factor. There's different prothrombin complexes that they can use. It's all very complicated. To me, I kind of feel like it's talking in terms of chemotherapy for cancer patients. There are so many specific drugs, and it's a very specific way of doling out medications. For von Willebrand's disease, it's the most common hereditary coagulation disorder with an incidence of 1 in 10,000. It is not linked to sex or the X chromosome. Various classifications for this from type 1 to type 9. So I was not going to go into all the classifications, but just knowing that there are severities of this. Somebody could have a very mild form that might not affect your care very much. And then for treatment, there's this DTAVP, which is something also that they talked about for hemophilia A and did I put that wrong? I think it's backwards. No, factor 8. That's factor 8. Sorry. I'm getting my Roman numerals all messed up. Okay, oral findings. Platelet deficiencies can cause petechiae, ecchymosis, oral mucosa, and promote spontaneous bleeding. So obviously those are things that we would think about. Gingival hypoplasia based on some of the medications that they might prescribe to them. Brown deposits on the surfaces of the teeth due to chronic bleeding. So if they do have spontaneous bleeding, just like anything that's a deep red, you might get some oxidation and some color deposit in calculus, and anything that's porous on your teeth is going to collect stain. And then higher rates of caries and periodontal disease. And this resource that I was reading through talked about predominantly because it might be that they are afraid to use the floss, might be afraid to brush, really like with their bristles at the gum line, might be afraid to use proxy brushes or toothpicks because they're afraid of the excess bleeding. So it would be a really important point to say, no, you have to get to health, maintain health. That will minimize bleeding, and that will be better in the long run. So like avoiding it is not the answer. So that was an interesting point. For dental management, some specifics, it totally depends on the severity and the invasiveness of the procedure. You should always have the physician incorporated in any discussions with hemophilia or any of these hereditary bleeding disorders. If it's because they're on a thinner or blood thinner, that's usually an easier conversation because it's like, well, are they going to come off the thinner for a while or kind of come off warfarin while they do this procedure? Oh, for dental hygiene, it's almost never going to be affected that they're going to have to come off of their meds. Um, Sometimes these different agents may be incorporated in the periodontal dressing. So an oral surgeon or periodontist, they may be more familiar with these kind of different hemostatic agents that they're added to the material to help control bleeding. Post-treatment, post-treatment antifibril, oh my gosh, nolic, I can't say it. My brain's not going to cooperate, but they have these mouthwashes that they might use as well post-treatment. For local anesthetic, just be cautious around doing the PSA. Sometimes you would just opt not to do the PSA block and you would do infiltration just for the risk of the hematoma. Good OHI probing and supragingival scaling is very often fine to do because you can do it very gently. All subgingival scaling is often fine if done carefully, but that's going to be a different conversation if the risk is higher or their severity of their condition is more severe. And then ultrasonic scalar oftentimes would be less traumatic because there's no cutting edge. You can control your, the tip a little bit better, maybe, you'll be a little bit more careful with that, perhaps, as opposed to like your Gracie's, with the being able to cause trauma at the end of the instrument or with the cutting blade. So ultrasonic might be more gentle. So might be what you would choose to use instead. But that's it. That's all that I'm gonna make you guys know for this class. There is more to discuss. You could always, do your own research on that or, take CE courses on it. But I feel like that's enough. So let's do this. If you guys go to the Moodle page and tell me if you want me to just print it off, we have about 20 minutes. It would be easier if we just went to the Moodle page and maybe I should have printed it off, but I just wasn't sure if we are going to have time, so I did not. But if you go to Moodle and then you go to week 6, it says case study for cardiovascular disease. If you go to that case study and you download it, and open it up and just type into it. And you guys, it's not an assignment. You could just have one person in your group be the recorder and type in your answers. And so let's do like maybe 10 minutes of discussion and then we'll do yeah, like 10 minutes of discussion and then 10-ish minutes or so of sort of just reporting out on what we see. So why don't we do this side of the room from like if I were to draw a line here, you guys start with the first case. And then this side of the room, Subhatra and over, you guys start just so that we can have, just in case everyone's not able to answer all of them. And if you get to all of them, great, in 10 minutes. But if you only get to one or two, we can have some different answers. So that first one that has the question 1 and 2, that's this half of the room. And then the Mr. T, age 45 for the 1 and 2, the other side. And then there is a Mr. B as well. So that can be whoever wants to answer Mr. B. So it's 10:26. So we'll go 10-ish minutes or so.
Oh, 8:45. Is that the room starting on this 8:45? Is it control for that? Or is it? How often is it about? How often? Yeah. How often that part was does it happen? Okay, some stress or exercise. Well, first here's how I would say. Should I have been explaining about makes sense. Yes. So the next one, not expired.
So sure. This kid. Regulate back.
Semi-supine. If patients are sweating. Keep track of vitals.
I know, it didn't really talk about it, did it? That was, look at, Google it.
Because that, I learned that. Kind of cool, then I think we talked a little bit about right side level line. But we didn't really do it. No, I'm just like. Because it was like if they have one side, they're more likely to have the edema. So
I know, when I was looking at that, I'm like, they might not be able to answer that, but based on today's PowerPoint. So just ask Chat GPT. Yes, one side affects one body more.
Right. To the lung.
I don't know, I just think it's gonna be beneficial. Yeah.
The shape. Let me check my lungs for flu.
Where's? For the first one, I'd say the conversation was special hard to see. Well.
Is it medication? If it is big medication.
Oh, first one.
You can make it medication. Let's uncontrolled hypertension.
But it's still a bit.
It's not uncontrolled. This is not something.
I agree, it's uncontrolled.
Oh, yeah. This is the same. Yeah. This happens a busy, fast paced. What?
Fair.
Greater experiences and growth as an individual. Listen to the words of wisdom. Yes. Yes. My soul's calling. Is that the yes?
I got enough for the next 5 years though.
Yeah. But they're
Well, when was
they gotta compare phone.
This is kind of periodic within the last year.
So
I don't know.
whenever they do this, my analytics is automatically comprehensive. So that's why it's fun.
And like 2
And the things that the level from the first FYI, but it's a 5-year gap. You know how we stay great. The 5 years can be from the.
Or did you already get into the rooms in the month?
I'm thinking about the pipes. You do a whole thing and you can get to one level if you didn't die. Didn't die. Humans have been growing. Like the actors. There's a I think Max in this is Korea. I think sequence vertical. Kinda has 3. With the vertical by points, it's like yeah, you get the level Kind of accurate.
Never even think of you for it was funding that's not.
They're like, yeah. Yeah.
So,
What did
Take it away now. There you go.
You know what you're pushing.
Yeah.
I love this. All this.
What am I gonna do? Yep. Question was to your menu. Actually, I walked. Yeah, you know why?
Yeah. It's a surprise. Well, yeah. You better be all.
I would love to see that.
No, I would.
Oh, my goodness. Oh, that was really good.
Wait. No, I. No, I just yeah. Everyone should know. I guess it's this point. I like five. He said.
Yeah.
Your brain was just kind of saying.
But if anything. Yeah.
Wait, can I do one?
Yeah. And then like, you know you're gonna
You did make me laugh. You like, it's like best kind of
That's a good one. I like the long them. They need a little bit more. Weight. Oh, yeah.
Is your tea on purpose?
I don't know. I don't remember. It was, I made this one either last year or the year before, but I might have.
This one's really good too. You can stand people and then get it down right here. You're not always getting right. You guys the middle.
Like that for now? Yeah. Last it all. They have a double one.
Yes, with all that water.
I was like.
is it 3,000?
Yeah, exactly. Okay, I'm just.
Take it away now. Take it away now. Take it away.
They want that last little bit, yeah. Everywhere, but it looks.
There's a lot of.
I know.
These are a lot of.
I know. I was okay.
You're done. You're done. You're done.
Okay, are you guys ready? Did I give you enough time? Okay, so let's start with the first one. So let me unpause this just in case you guys find. Oh, wait, I never stopped. Pause recording. Okay, I guess I never stopped. All right, you're gonna have to fast forward then. Um, where'd it go? Where'd my, there it is. Okay. Okay, so while taking the vital signs of Mr. J, he's age 52, the dental hygienist obtains a blood pressure reading of 142/90. The dental hygienist waits 10 minutes and repeats taking the blood pressure, obtains the same reading. Mr. J is surprised that this blood pressure reading is high. He then mentions that the last time he went to the physician was 2 years ago. He states he's not been to his physician because he does not have time, placing the blame on his busy and fast-paced lifestyle. What should this patient receive? Should this patient receive dental hygiene care at this particular time? Why or why not? Who wants to be brave?
He's the normal rate for the clinic. I mean, it is uncontrolled, it's hypertension stage 2, but he still can receive treatment, but he should leave with a COC.
Yes, good start for that for sure. Technically, he's in range, right? We don't know if he has comorbidities because he didn't tell us and I didn't write it in there. So that could make a difference. But from just taking that at face value, you could. So now you kind of think, okay, if I'm just taking this at face value, then think of some ways. It's really easy with patients who are very dismissive to just sort of follow their lead and be like, okay, I'm not going to browbeat them. But it's also sometimes they just simply don't want to acknowledge or hear that high blood pressure is a problem and that it's not healthy for them. And it's that silent killer. And so having sort of a very concise, compelling, non-lectury way of dealing with patients who have high blood pressure and just sort of poo-poo it, like, oh, it's not a big deal. That's just my normal. It's fine. Or it goes away. Anytime I'm not here, it goes away. It's like, okay, but every time you're here, it's this number. And so, you're dealing with this kind of like, their reality versus what you want to share, or what they want to acknowledge as an issue. So anybody have anything else to add to that before I kind of scroll down? What did I say? What was the question? Should this patient receive dental hygiene care? Why or why not? Would there be any reason to not?
Not with the information we have. Yes.
True. Good thinking. Yeah, not really. I mean, in general, it's not like just having a high blood pressure puts them at some kind of huge risk, right? There could be other things going on, and that's what we want to precaution. But in general, so let's see. So based on blood pressure readings, we're within normal limit. There's just and I can open up this key for you guys too. I can put this in Moodle, but there's just a reminder of things. Typically, dental treatments can be proceeded with caution. If somebody has a stage 2, hygienists should monitor the patient for any signs of distress. Caution with local anesthetic, all of our things should sort of be at the back of our mind. Caution with vasoconstrictors like epinephrine, limit the use, temporarily increase blood pressure. However, in general, we find that it's not a big deal. Therefore, Mr. J is in general safe at this appointment, but we want to be mindful of the condition. Number 2, based on the current situation of this patient, what patient education would you give? How would you kind of make an elevator speech to them about seeing their physician or taking it seriously and following up?
We just
they took them over for evaluation and management, but then also we talked about risks, or not the risks, but like how to manage it. Like stress management, using alcohol, things like that. Basically.
And you can, I mean, they kind of gave a little teaser in the case, but just he acknowledges he's always busy, doesn't really have time for that. And it's like, oh, they just gave me a segue. So just like you said, kind of some lifestyle, acknowledging maybe what they've already disclosed as, you know, they have a fast-paced lifestyle. Anything else?
I think just showing genuine concern and care. Like I really care about you as a patient. I remember Lindsay had someone in that situation a couple weeks ago, and she was just saying over and over to him, like, I'm genuinely worried about you and like care about your well-being and I want you to be healthy. So
Yeah.
I think that like kind of strikes some fear in them, but like in a good way.
Yeah. I mean, I think it would be like, I think that's a great point. I think when you realize that the person, you know, so often when you go to the physician, you know, the medical assistants, the nurse practitioners, the nurses, the physicians, they are so rushed. And I have gone in and like my husband has high blood pressure and I've seen them take his high blood pressure and then be like, oh, that's normal. And I'm like, 90's normal on the diastolic? I'm like, what? And they share no information. Yeah.
Yeah, what Rachel said, my patient, he had just been to the doctor and they had told him he needed to take this medication. His wife had been on him about taking the medication, and sometimes it just takes a third person or multiple perspectives, but he was like, yeah, I haven't been taking my medication. I felt better once I took it, so I stopped taking it. And I was like, I had to explain that's not how it works. You know, it's blood pressure medication. You have to take this for the rest of your life. And he was like, yeah, my wife's been sending this. And so we sent him away and I called him and he's been taking it for 2 weeks now. So
It really is true. I think, you know, that's why we're more than just teeth scrapers, because a lot of times we do approach things with a more care and time, and it really can make a big difference. So that's awesome. Okay. You guys will all develop your own way of sort of, talking to patients. But okay, so some things, patient management, let's see if we have some little tidbits in here that are just, so this is obviously probably too much information for any one person to give, but it's just reminding things like dental, you know, high blood pressure is a silent killer. So you can talk to them about the stress that it can take on the kidneys. And, you know, there's a fine line. You do what comes natural. If you're a nurturer and a carer, you can come from that. If you're like a fact-based research, like, let me share what the research says about untreated high blood pressure, you can come from that perspective. But talking to them about diet, exercise, stress management, limiting alcohol and tobacco, just like Kelly was mentioning also, medication adherence. It's not just like, today I feel like taking it, tomorrow I don't. Like, you just have to take it. And if it's causing side effects, then they need to talk to their doctor about that. There's lots of meds they can change to. My dad, lots of patients I've had through the years it takes time to dial it in. Follow up, the hygienist should also make a note in Mr. J's chart about all the things you discussed, their adherence, their cooperation, and yada, yada, yada. Let's get to Mr. T, age 45, states in his medical history that he has angina. What further interview questions should the dental hygienist ask to ascertain the stability of the patient's angina?
It was their last angina episode.
Yes.
Last.
Yes, how long did it last? When was the last one you had? When did it last? How long did it last?
Was it controlled?
Is it controlled or uncontrolled?
Do they have nitroglycerin on hand?
You're just spouting them off. Do they have their meds? Yeah, good. Anybody else? Anybody else?
those were mid-emergency video.
Yeah. You guys are like, this has been great. This one's pretty straightforward, but it is, you know, it's one of those things. I remember having one older patient, a female, and she was like, oh, I'm just having an angina attack. And I was like, okay. And, and she's like, like, I'll just take my pill and it'll be fine. And I was like, okay. And so she took her pill, and then the whole time you're just staring at them. You feel better? You feel better? And you just want to like kind of you just want to, until they say my chest pain is gone, you usually just, it's in your brain, right? So when they first come in, if you can kind of get their baseline and get, because if it's like, oh, I never have an anginal attack and all of a sudden like, ow, then, it's a little unnerving. You don't want your patient to have a heart attack in your chair. But okay, so what do we have here? So interview questions. This is all the great stuff. What you said, when was your last angina attack? What triggers it? There's a little bit more supportive information. What medications do you take? Do you have them with you? How often do you experience the episode? Has there been any change in your frequency, duration, intensity? Does the chest pain radiate to your arm, neck, and jaw? So now you can start to differentiate, like, is this just a normal attack? Or are we having a heart attack here? How does rest and your medication affect your pain? So lots of good questions. I don't want to hold you guys over. I will post the key because there's lots of good just supportive reminders in the key. So I'll post it in Moodle when I go sit in my office. And you guys have a good rest of your day. You're welcome. I get, you're going to clap for me, Victor.